welcome everyone. It is Wednesday, May 13th, House Healthcare. We are going to walk through some proposed changes to S-197 based upon like committee discussion and working with Ledge Council. So if Jen, whenever you're ready, if you want to come up. This is a good time for me to like level set 197. I guess I want to set expectations of what we were given in Senate and wanting to support the work that the Senate did before crossover on this, because I know they took a lot of time with this. Well, at the same time, you know, the testimony we've taken and kind of getting us onto a path. So I think the language that we're going to look at, which is posted, is it posted, Tasha? Okay, language that's posted, you know, sort of lays out what our intent is, but also realistically sets what we can achieve this year. Because we're running out of time.
Okay. Jen Kirby, Office of Legislative Counsel, and also just to say that the Senate is on the floor and people monitor for me, but I may have to.
If you gotta go, we'll just break.
Jump up and run.
We have nothing until noon, so. Those are our bills on the floor, so we're wanting you to support those.
611 just happened. Thanks to my sources. All right, so this is a new draft of S-197. It's 1.3, but you haven't seen it yet because I've been working on stuff and having it edited and all of that. So it has been through editing. So all of the changes from the bill as it came over from the Senate should be highlighted in yellow. The first section should look fairly familiar because we had talked about it on Friday. So this is me trying to operationalize largely what you had talked about. It starts off saying it is the intent of the General Assembly to invest in primary care and to establish a program of universal primary care that is accessible to and affordable for all Vermonters, and will promote the public good by, and then this is thanks to Representative Goldman sending me the quadruple aim, by improving the patient experience of care, improving population health, reducing costs, and improving the well-being of clinicians and staff. And then it says the purpose of this bill is to obtain the information necessary to develop a framework for implementation of universal primary care, including optimizing the blueprint for health to determine whether it is an appropriate mechanism through which to provide universal primary care. Just keep going.
Unless anyone has, and I am open to feedback, certainly open, absolutely. So
line 10 on page 1, to establish a program of universal primary care. That reestablishing a program or a system?
I think it's a, I mean, system is your healthcare system. It may not be a program, but it's something I needed now. So. So maybe we can go through the whole bill and then we can think about it. Okay. Section 2 is the blueprint chapter that we had looked at before. Much of the language is unchanged until we get to the spending targets. And I struck out that codifying that language, but I have put the first 2 sentences in as part of the study in section 3. So as far as establishing a target, for per person per month spending that should be for primary care, transitional schedule with targets that may be adjusted. But the last piece, the part about the increased spending shall be directed to the per person per month payments, is not included.
Yeah, and if you recall, that's something that Nolan, that you flagged a little bit for us.
Well, I think
And-
he had wanted to discuss the per person per month spending. I think it's the last piece that the increased spending shall be directed to the per person per month payments. That was the part that was actually operationalizing the blueprint as the source of funding for the expanded primary, the single primary care payment.
Yep.
For all services. So this is not taking that step forward at this time. Section 3, and you'll see throughout, there were some reports, we usually do reports January 15th. There were some reports that had a January 1st due date, so we've moved those to January 15th. So this would still have by, let's just say January, the director of the blueprint in consultation with the Blueprint Executive Committee and the Vermont Steering Committee for Comprehensive Primary Health Care, reporting to this committee and Senate Health and Welfare regarding changes to the payment amounts or payment reform methodologies, or both, that are necessary to transition blueprints per person per month payments to primary care practices to include payment for primary care, routine primary care needs of attributed patients who are covered by participating health plans. Maybe it should say that would be necessary as opposed to that are necessary. I think this is, I think, largely informational at this point. So I'm just going to say. And then the report shall, and it keeps a lot of the same things with a few new or expanded ones. So this, and the first, we're not just defining what services should be considered routine primary care, but establishing definitions of primary care services and primary care provider, and defining which services should be considered routine primary care. And then it continues to talk about differences in methodology for different practice types, recommendations on risk adjustment and attribution methodologies, describing ways in which the methodology will balance capacity, volume, quality, and outcomes, include mechanisms for ensuring plans make accurate and appropriate payments to practices in a timely manner, make recommendations on participation or quality measurement requirements, or both, provide an analysis of including cost sharing amounts for individuals covered by participating health plans in the methodology, including the extent to which the inclusion would be permissible for high deductible health plan. And then we have what I moved over from the struck language in the previous section. So establish a target for the amount of per person per month spending on Vermont residents that should be for primary care services, and develop a transitional schedule that increases that target over time, adjusting targets as needed to reflect payer specific differences such as age and health status. And then adding a new, amending what becomes number 10 on the operational plan to add not just an operational plan and description of additional legislation needed. The language in the bill as it came over to you talked about language needed to implement the methodology not later than January 1st, 2028. This would instead have a proposed timeline for implementation. And then number 11 is new, and it would say provide a description of the ways in which the blueprint can optimize the delivery of the services within each of its current initiatives, the costs associated with enhancing each initiative to its highest level, and the amount of additional per member per month spending that would be needed to support the enhanced delivery of these services across all blueprint initiatives. This is what you had in mind?
Yes.
Okay.
Thank you for making my word salad as I was trying to. So what I was trying to essentially get to is, the blueprint has all these different delivery of services, and what are there gaps in that? Could they be further optimized, and basically what it would take and what would they need to really fully meet all the needs that are needed. Again, thanks, Jen, for the really great language around my incoherent thoughts. Leslie.
So just so I understand, this, and you may go further. To me, this seems like this language is just looking at what the blueprint is currently doing and not necessarily what we think the blueprint could be doing. Because in the original bill, it was expanding the blueprint beyond, routine primary care. And this doesn't seem to say that.
You
And
mean number 11
Yeah, yeah.
specifically?
And
I
maybe
think
it's
that's true. I
elsewhere.
think it's looking at what if the blueprint were to achieve its sort of full potential with the way it is currently configured, what would that look like? What would it cost? And
but it
then
would still be within those limiting.
for number
They only
11,
do 4 things or something. I mean, if I remember right, they have the pregnancy thing and they have,
right,
SUD.
right. But I think a lot of the rest of this is looking at the blueprint. This one is looking at,
So that's 11, but as you go further, you look at a broader.
I would say what comes earlier was the broader.
Can you point me to that?
Well, it starts off with the blueprint reporting on changes to payment amounts or payment methodologies that we
Page 6.
needed. This is on page 6. It would be, this is in the language that came over from the Senate, that are necessary to transition the blueprints for person per month payments to primary care practices to include payment for routine primary care needs. And then it's having them do all of these definitional services.
Yeah.
Right.
Yeah.
And then number 11 is just,
Just their
Yeah.
current state. Okay, thank you.
I think the thinking behind what I was trying to get to, Leslie, is, I mean, we heard in testimony from the blueprint that they're actually engaged in, I think Dr. Soroyan used the word modernizing the blueprint.
Mhm.
So if the blueprint moving forward, as we move towards universal primary care, if the blueprint is going to be the mechanism in which we do that, then they should be modernized to the best of their ability for us to be able to make a decision on whether or not that is the right methodology moving forward. So they need to be doing this anyways. And in order for us to make actual real coherent decisions around how this is going to be implemented, we want to make sure that they're functioning at the highest capacity that they have possible, sort of.
So could there be language, and I'm back on page 1, I guess, and I'm not sure if this is when you want to talk about it. In the B section, which says including optimizing, for me, when I read that, it sounded like the blueprint was sort of default being chosen. And I'm not sure that's what the language necessarily says, because it does say including optimizing, but could there be language? And I have no idea what the right language might be, but with the idea that there may be a whole nother mechanism that we haven't thought of yet.
Well, that's sort of so remember, we're still in the intent language of what this bill is doing. And the bill, as it came to us, is really about optimizing and modernizing the blueprint. So that's still the intent of the bill, which is why we have including, so the intent is to optimize the blueprint in order to determine whether it's going to be the appropriate mechanism.
No, I read that and I can read that, but what I'm saying is, could there be language or another or something else yet to be determined or something like that? I mean.
well, it says
like-
whether it is an appropriate mechanism.
Among other,
Yeah,
others considered. But maybe that's not the right place for it, but I agree.
yeah.
I don't think we're asking the blueprint to report back on whether or not they're not the appropriate mechanism and what else would be the appropriate mechanism. We're more asking them to modernize themselves so that we can make the determination on whether or not they're the appropriate mechanism.
So my preference would be take out the sentence starting on line 21 and not even mention the, period, purpose of obtain information. And then you were going to go on and talk about the blueprint. So,
Yeah, but in the intent section where the intent section has to relate to what's in the bill, and that's what's in the bill.
what's in the bill is to optimize the blueprint, but it doesn't necessarily have to be related to universal primary care. I mean, it just seems, that's my reading of it.
Or it's just.
Yeah, at that point. Maybe we just remove the word optimizing, including the blueprint for health as an option to blueprint for health to determine whether it is an appropriate mechanism for which to provide universal primary care.
And any others that might be created through this process. I mean,
Right, but I think the first part gets to that.
that's why I don't know why we need that part.
It does seem to narrow it back, or it does seem to indicate on a quick reading that blueprint is being the one emphasized, but maybe we read the whole bill and then come
Yeah,
back to this.
Finish reading the whole bill.
Page seven. Page seven, yes, page 8. So this was the list of what's supposed to be in this report from the blueprint, and then in B, it says the director of the blueprint or designee shall be available upon request from July through December 2026 to provide updates to the Health Reform Oversight Committee on the development of the report required by subsection A. And then section 4, I think has not changed. Section 4 is the primary care spending, again, changing to January 15th. And having the Agency of Human Services in consultation with the Green Mountain Care Board, reporting to this committee and Senate Health and Welfare, the baseline per person per month spending on primary care services for Vermont residents overall and by each payer. And instead of having the agency use the definitions from the AHEAD model or NESCO, it would have them use the definitions of primary care providers and services established pursuant to section 3A. Where we had said.
Where I said,
Those definitions.
what's the definition of primary care?
All right, section 5, as it was in the bill, is no longer really relevant because we've moved the per person per month spending targets to the report section and pulled out the sort of codification of applying those. Put in a different section 5. This is on distribution of duties for healthcare regulation and healthcare reform. This would direct the Agency of Human Services, Green Mountain Care Board, and Department of Financial Regulation in collaboration with the Office of the Healthcare Advocate to evaluate the roles their respective organizations play in healthcare regulation and healthcare reform in the state, including with respect to hospital transformation efforts, health insurance rate review, management of the Office of Healthcare Reform, operations of women's health, and administration of other programs and initiatives. I would have the agency, board, and department collectively determine where each healthcare regulation and healthcare reform function should be most appropriately located in order to optimize collaboration, information sharing, and efficient operations, and furtherance of attaining the principles for healthcare reform from Act 48 and as codified in the Green Mountain Care Board statute. Chapter establishing universal primary care, improving access to high quality, affordable healthcare services, accomplishing healthcare transformation, and safeguarding hospital sustainability and insurer solvency. They would, the agency, board, and department would provide their joint recommendations by January 15th, 27, including areas of agreement and disagreement, gaps and overlaps identified, and any legislative changes needed to this committee, Senate Health and Welfare, and Senate Finance. And it would also require them to be available upon request from July through December 2026 to provide updates to the Health Reform Oversight Committee on their efforts and the development of the report.
Okay.
Oh, I thought you said, oh, okay.
She made a noise.
I heard Did you have a question? No. Okay.
Leslie? I'm not sure when you want to talk about this, but on section 5, what problem is this section addressing? what is not happening now, and I'm not sure I understand what the confusion is with these three different agencies and what this report. Help me understand it.
What problem are we trying to solve? Well, first of all, we're just asking them to talk amongst themselves about where and we have heard in testimony over and over on many different bills, many different topics. You know, we have, like, the Department of Financial Regulation is tasked with insurance regulation and insurance solvency, while we have Green Mountain Care Board, who's setting rates for insurances based upon, you know, affordability for Vermonters. And, you know, we often hear, and this is not a criticism of anyone in any way, because everybody's working really hard in the things that they're doing, but sometimes they compete with each other. You know, we've established that the Green Mountain Care Board, or we've tasked the Green Mountain Care Board with establishing reference-based pricing for hospitals. But then at the same time, we have the Agency of Human Services on hospital transformation. So it's not saying that, you know, either of these parties are not working diligently on what they're trying to do. It's sort of like, okay, Green Mountain Care Board, how do you establish reference-based pricing if you don't know the services or needs of a hospital that AHS is working on to ensure that hospital transformation is happening. So it's just them sitting around discussing things like, you know, I mean, if we're going to move forward with universal primary care, should that be in the health reform, Office of Healthcare Reform? And if so, should the Office of Healthcare Reform be within, like, the Agency of Human Services? Is that their task, to implement universal primary care? Or is that the board's task to implement universal primary care? It's just sort of a question of, is everybody working with all the information they need to be able to make the best decisions around what their task, what we've tasked them with doing? That's the problem we're trying to solve. And this is actually not a solution. This is them talking about, you know, where things should be. I don't know, perhaps Lori might, you know, hospital in Act 167, we tasked the Green Mountain Care Board with hospital transformation, and then they did the Wyman report, and then we moved hospital transformation to AHS. And so, you know, was that the right thing? Has it achieved what we wanted to achieve with 167? Or has it created like a whole new layer that was unintended? And so this is what this is really trying to get to do, is look at what everybody's doing and figure out where things should best be housed so that everybody can achieve to the best of their ability what we've given to them.
Yeah, and I'll just say,
Because I asked you because you were the history of.
yeah, and I mean, I think this is great, because I do think, you know, when we have a big problem, right? And we have different divisions doing different things. Nothing in my mind, and I'm sure everyone else's here, is moving fast enough. And so, and we have turf wars that happen sometimes, no fault of anyone's. And so I personally think this is really important to try and make sure we are finally moving things forward and the right people are doing what they're supposed to be doing.
Can I
Yeah.
My curiosity
What kind
is-
of problem are we trying to solve?
Yeah, my curiosity is that, so we have the big three, let's say, in a room. And then they are tasked with whatever, duking it out. I'm unclear on how this process happens. I remember there was a bill that came out of the Senate asking for AHS to look at themselves and evaluate their structure. And that turned out to be pretty much of a dud. So I don't see how this process. I'm not sure. I mean, and I'm seeing it for the first time, 5 seconds, and had no time to. And we haven't had time as a committee to think about it or with witnesses. If this is the right structure to think about looking at the problem, it doesn't appear to have any input from anyone outside of them. So where's the public? Where's anybody
The
other?
healthcare advocates in the room. Lori? Oh, I'm
I was
sorry,
gonna-
Leslie,
I would-
you've done your-
I don't see where the healthcare, okay, there he is, great, thank you. Which is great, of course, Go ahead.
I was just gonna say, I mean, I have a lot to say on this as well, but I don't think we're done. Are we done?
Close.
We are not quite done yet.
That's okay.
You want to wait till we're done? Yeah, let's finish, let's go through the changes.
Section 6, just updating that date to be January 15th for the Green Mountain Care Board, updating its reports on clinician landscape and site neutral reimbursement. Section 7, no changes, just transitioning care to community settings, already had a January 15th date. Section 8 is a report on universal primary care efforts in other states. This directs the Office of Healthcare Reform in the Agency of Human Services to examine efforts that have been undertaken or are currently underway in other states to establish universal primary care, including the methodologies, funding mechanisms, implementation plans, and timelines considered or pursued, or both, and any legal or regulatory obstacles identified and potential solutions explored. On or before January 15, 2027, the office would report to this committee and Senate Health and Welfare with the most promising opportunities identified and lessons learned, and how those compare with the approaches to universal primary care contemplated in this act. And then no changes to section, what is now section 9, the regional universal primary care, sections 10 and 11 are just renumbered as in section 12, and I flagged that the bill title may need to change.
Terminology.
Yes.
There's the health reform, or I can look them up, oversight committee, and then there's the Office of Healthcare Reform, 2 different entities.
Health Reform Oversight Committee is a legislative committee that meets when the General Assembly is not in session.
Okay,
The Office of Healthcare Reform is in the Agency of Human Services, and they're the ones who are leading hospital transformation and other.
yes.
Actually, can I reach out to someone on the bench? Maybe not. Agency of Human Services. Can you give us the organizational structure? I think I have it right in that the AHS central office, within that is Medicaid, essentially Medicaid policy. Underneath that, that would be the director, like Jill Olson. And then underneath that is the Office of Healthcare Reform. And then within the Office of Healthcare Reform, underneath that is the blueprints, or where is the? Yeah, I'm trying to figure out what the org chart is.
Yes, Eli Hoggett, Agency of Human Services. That's correct. Within the Agency of Human Services Central Office, there is the Department of Medicaid Policy, which works closely with, but is separate from the Department of Vermont Health Access. And within Medicaid Policy, that is our director, of Medicaid Policy. Blueprint, is separate from Medicaid Policy.
Okay.
But it is within that central office structure. And so, within that structure, there is Medicaid policy, there's Blueprint, there's, the Office of Healthcare Reform, which is also separate from Medicaid policy, but also supervised by Director Jill Olson. And then we also work closely with, Vermont Chronic Care Initiative, which is within central office, and oftentimes, that collaboration also informs some of the Blueprint initiatives as well.
Great, thank you, sir.
When you say central office, you're not talking about the secretary's central office. You're talking about DIVA now?
No, so within central office, it is the secretary's central office, and DIVA is within the umbrella of the Agency of Human Services, but it is a separate sister
Yeah.
department.
Got it.
I think what I just understood from your answer is that if we looked at an org chart, that we would have the secretary, underneath the secretary would be the director of Medicaid. Equivalent and opposite of that, we have the Blueprint, equivalent and opposite that, or also reporting to the secretary, we have the Office of Healthcare Reform, and then the other one that you talked about, Chronic Care Initiative. I thought I understood that they sort of went down from the Medicaid policy.
All of these are supervised by Director Jill Olson.
Okay.
But Medicaid policy, is a separate offshoot from Blueprint, both supervised by Director Jill Olson.
Thank you. The org chart. You have it?
You have it?
Email it to us?
Yes, if you could.
Thank you.
All right, so those are the changes that that working with Ledge Council was, sort of thought it was incorporating some of the ideas we had. Again, I just, as the bill that came to us, it was really about kind of moving forward in a path to, I felt, set the blueprint up and steps that the blueprint would need to take for us to then move the blueprint forward in some sort of more universal primary care. And I do think that this work needs to be done at the blueprint. The blueprint has already said that they're engaging in this work and, that there are lots of things that need to be done. And I think that it's really important that they be allowed to continue that. And also through that work, we can gather more information as we make decisions going forward, whether or not the blueprint is the right mechanism for doing this. And so I'm interested in people's thoughts or concerns or additional language or language taken away or maybe, yeah. Please.
Looking at page 9, section 5, with the Agency of Human Services, Green Mountain Care Board, and Department of Financial Regulations, in collaboration with the Office of the Healthcare Advocate. What do you envision that being? Do they have any input on how this is, or do they just?
I will tell you that I've actually had conversations with all these organizations.
Yeah.
And they're already talking amongst themselves. this is really just saying, continue these conversations you're having amongst yourselves. And we really want to know what the outcome of those conversations are. And the healthcare advocate, because, you know, the healthcare advocate represents Vermonters, and they are outside of legislature, the administration, the quasi-governmental regulator, the Green Mountain Care Board. It's the Office of the Healthcare Advocate is hopefully somebody that will provide kind of an unbiased. It's not that in collaboration with means that the healthcare advocate is the one that does this. It means that they just have a seat at the table as part of the conversation that these various agencies are having with themselves. That's.
Can I follow up on? Yeah, because I had a similar question. I'm not sure I understand what in collaboration means, because they could be excluded easily. Because they're not officially at the table, because it's in collaboration. My preference would be that we just say they are included and not say in collaboration.
I absolutely understand what you're saying. I don't know how to make them included because we're not asking for
Well, because you're talking about.
things to be housed in the Office of the Healthcare Advocate that, you know, that I'm trying to, I guess, I mean, is there a word that we can come up with? Supervise.
Yeah, collaboration, I think. is the word.
Collaboration is sort of like the words I think we came up with.
I see that. I see your point totally. But I also could see how it excluded, you know, that I just don't, you were gonna raise your hand.
What would consultation be more in consultation?
I mean, we use those words a lot. I see consultation potentially being less involvement than
Yeah.
collaboration.
Like, hey, we had a meeting and here's what we talked about.
Yeah.
Collaboration.
It's like, because when you go on to the next page, the Office of the Healthcare Advocate is not really mentioned in the first paragraph. And that's why I missed it, because it's down at the bottom. The agency board department to collectively determine where each healthcare regulation, healthcare reform should be most appropriately located. Wow, that seems like just such an opportunity for conflict. I'm struggling with that. And who's the leader? I don't know who in here is leading this process, and I think there always needs to be reliable leadership in who sets the meetings, who sets the agenda, who, you know, all that work is really fundamental to any process moving forward. And that's why I'm a little stuck on that.
I hear that. I think the goal is to make it informal. And I think I'm anticipating conflict. And that's why, you know, that's why they have to report back, not just on what their recommendations are, but where the conflict was and the reasoning for the conflict. Because I think that if they have to report back to us where the conflict is, it allows us to make better decisions about where we want to put things.
Well, that's asking us to be the referee again. And if that's the intent. Go ahead.
No, go ahead.
Well,
I'm
you raised
just
your
putting my, well,
Yeah.
I'm just
No,
letting you
I
know.
was
what to go
sort of
next.
babbling. once again, I mean, I'm not comfortable with that as a process. But I guess I can just say that.
But what process do you have suggestions on?
As I say, listen, I'm seeing this for the first time. I don't know your object. I mean, you did say something about your intent, but I'm not sure I get it. So, I mean, that's just, that particular section. I'm not seeing that as productive.
Can I go?
Yeah, go ahead.
I don't think this is a standard process. I see this, how I am taking this, if I agree to keep this in and vote on this bill, that hospital transformation has taken far too long. We have a health system in crisis, and we're getting piecemeal ideas from various parties, and no one is in driving the whole thing. And so we need to say our intention to all of these parties to get in a room and figure it out. I'm going to be clear on record that this year I wanted to pull money away from hospital transformation and give it to something else because it's not happening how it's set up right now. And we could sit here and try and find a way to dictate to do it, but that doesn't mean our intention will be followed. So in my eyes, this isn't a normal process. This is just get in a room and battle it out. And you better come back with some ideas because the legislature is tired of this. I will say I'm tired of it. I won't speak for all of them.
And I will say on record that the thought was removing hospital transformation from the Agency of Human Services because it is not happening fast enough. It is not happening with urgency. And that was not agreed upon by all parties. And this is getting people in a room and figuring it out and come back to us and come back with clear justification of why things need to be where they are. Because we're just working on turf wars at this point. And as Lori said, you indicated that this seems like a turf war and that there will be great conflict in this. There's already great conflict and there's already turf wars. And the legislature needs to make the best decisions that they can in how to, get to the aims of where we're trying to get to. And unless we know about that conflict, then we can't do anything.
But all these organizations pretty much have their roles. I didn't raise my hand, I'm sorry. Established.
Okay, we'll keep talking.
Yeah. In statute, I mean, it's pretty clear what some of it, maybe not all of it, but I imagine that's where it would start. Green Mountain Care Board has a statute. We know that Healthcare Advocate has a statute. We know DFR. I mean, some of these things already exist. And I agree, it is certainly not moving fast enough. But I've seen West Side Story enough to see what happens. People die. And when you let people in a room killing each other, I just am very uncomfortable.
Really, really helpful. Yes. Daisy.
I mean, I'm sorry, I'm not saying you're gonna kill each other, obviously. I'm just saying, when we talk about turf war, and someone brought up that idea, not me.
Can we just kind of zoom out? I think that overall the changes that were brought in, including the quadruple aim, which I think is incredibly important framing, are wonderful changes. Wonderful. And I wish Jim was here because I think her wording through this is fantastic. I think that you all preserved what the Senate sent us and worked so hard on. But also incorporated what all of us have been hearing for years around exploring the possibility of universal care in Vermont and universal primary care. And I think this is wonderfully done. I think that, listening to Leslie's concerns, I think they're really valid, but I also think that this language in section 11.5 is going to bring us a report that brings us into the conversation. So I fully support this as it's drafted right now, and thank you for working on it. It's wonderful.
Did I see, Aaron, did I see your hand to go up?
Well, I'm just ruminating. I'm happy to think about my head. In the collectively determined section, I think it'd be really difficult to name like a leader or someone that sets an agenda within that context. They might not collectively determine, they might not come up with that, but they might be able to identify why they didn't, and so that's valid information. Is the healthcare advocate at all included in the being a thought partner in the collectively determined thought? Or are they just they sloughed off?
No. They're not just there to observe. They're there to be an active part of the conversation. The reason why it's in collaboration with them is because we're asking these three agencies to think about themselves. And because we're not thinking of the Office of the Healthcare Advocate of being also involved in where things should be, it's really just that he's an unbiased collaborator.
So on page 9, line 20, there's the in collaboration language. On page 10, line 5, 6, it's agency, board, and department, but there's no healthcare advocate mentioned at that point. And is that intentional?
Yes. Because he's there to help facilitate. And I'm sorry, I keep saying, I think the Office of the Healthcare Advocate is really in a facilitating role. And I will tell you that one of the reasons that there's not a lead on this is because they each have an equal responsibility. And anytime we have said, and I can think of so many bills where we have said, the Agency of Human Services in consultation with the Green Mountain Care Board, or the Green Mountain Care Board in consultation with the Department of Financial Regulation. The moment that you put that person or that entity in charge, it's just, which is sort of what I'm trying to get at here is, we, the legislature, we agonize over every bill that comes before us about who's going to do it. And you said, aren't these things already in statute? And one of the problems that we have now is that we have put so many things in statute and given them to the loudest voice in the room at the time, that things are not jointed correctly. I will just, or also that a lot of these tasks and these things that are in statute, they're iterative and they have changed over time. Like the Office of Healthcare Reform. The Office of Healthcare Reform was established, and it was originally in the administration. It was in the governor's office. And it was established around to try to get us to universal healthcare when Vermont was doing that. Well, that's not what they do anymore. And over the years, we have, said, oh, why don't they do this? Why don't they do that? And they've moved. I mean, they were in Diva for a while. Then they went back to the central office. And then I think they went back to Diva. No, they've only gone back and forth one time. Okay. So they've actually moved, and their tasks and their charge has changed over the years. And I just think that this is a level set of these various agencies to talk about, where things are and what the tasks that they're trying to achieve now are. And where they should be housed so that they can actually move forward with the things that they're all trying to do. Dave?
Yeah, so originally I was looking at it going, how are the three entities gonna come up with a plan? But then in reading that through July, you probably know where I'm going, that the Health Reform Oversight Committee will check on the progress. Where do we stand? So I think.
What have you guys been talking about?
Yeah,
What do you-
exactly.
Yeah,
Yeah,
where are the pitfalls? Where are the hiccups? where is the agreement? Where is,
yeah.
Yeah.
And through this process, the
Yeah.
healthcare advocate will be able to
Yeah.
collaborate and say, as they move along, have you thought of this? And that kind of stuff. Yeah.
yes, we, go ahead.
I think I heard you say, but correct me if I'm wrong, that you saw the healthcare advocate as the facilitator. Did you just say that?
I'm trying to think of words, supervisor, facilitator,
Well,
Collaborator,
advocate,
a voice in the,
facilitator.
a voice in the room.
Facilitator is a word that's a leader, an organizer, who makes the process happen.
or keep things on track.
That's right. So if we made the healthcare advocate the facilitator, that would relieve me.
Oh,
I'm not, I mean,
No.
he would probably say, no, thank you.
yes. I believe.
But you said that, you said you saw the healthcare advocate as a facilitator of something.
I see him as a non-biased seat at the table.
But everybody's biased. And that's, of course, where I struggle with this language on the first page of, implying that the blueprint, well, is a contender, let's say, and that is a huge bias in setting up this bill for me. So, yeah, that obviously, but this, and it's really 7 reports, right? It distills down to 7 reports.
No, I think we even got it down further. I know, I think it's now 3.
Oh, well, let's look at that because there's a report. Section 3 is a report. Blueprint payments to practices in primary care. Section 4 is a report, primary care spending, Agency of Human Services. Section 5 is a report, distribution of duties for healthcare regulation and healthcare reform. Section 6 is a report, Vermont clinician landscape site neutral reimbursements. Section 7 is a report, transitioning care to community settings. Section 8 is a report, universal primary care.
Hold on one sec. Hold on.
9 is a report.
Hold on. So section 5 is not a report. Section 5 is provide us with your recommendations.
Section 5 at the end says report, distribution of duties for healthcare regulation and healthcare reform report. That's what it says. Now, the language is long and whatever, but it's a report, right?
I see it more as a report back.
Can I ask why you're concerned about so many reports? Like what's?
So what happens with all that? There's a whole lot of work being done. The treasurer wanted $350,000 for the, it's gone, obviously. Who's going to pay? How does this all get implemented?
None of these reports have been a appropriation requested by any of the agencies.
And we've all lived through all the reports that sit on shelves.
And in order for us to move forward with universal primary care and to make the best can I ask something about section 5? So when we move forward in universal primary care, we, the people around this table and people in the Senate, will be tasked with figuring out who's going to implement it. We will have the same various agencies in front of us, either asking not to be responsible for it or asking to be responsible for it. The reason that we're asking them now to be thinking through what they're doing and how they can best work concert with each other so that we can make an informed decision about who we're going to task with implementing universal primary care. So, I mean, that's one of the reasons that I think it's so important. And these report backs are really just for us to have the information we need to take the steps forward that we want to take. That's what I'm seeing this as. Did you have?
No comment.
Okay.
Yeah.
Yeah.
Kind of a weird question, I guess. If, number one, all of a sudden we got universal primary care. What exactly are we talking about with I know what definition universal means, but can you explain this in this bill?
What is universal primary care? We had very robust discussion yesterday around the word universal, didn't we?
Yesterday?
We weren't
I missed it.
included in that.
Val and I were working.
Okay, that's all- that's
We're
fine.
Working with legislative council.
Okay.
And, universal, available to everyone, accessible, affordable,
And when we say everyone, that's the whole spectrum.
Vermonters.
Okay. So then my next question to follow up on that, we got a report on section 3 to establish a definition of primary care services.
Yes.
Did you discuss that too? Yes.
No, I will tell you, we actually, so this was kind of the original bill that came over. And this is something that the blueprint already does and AHS does. When it says primary care services, if you're going to be able to decide that if we were ever to do like a sort of a capitated payment model, what you have to do is you have to decide what services are actually primary care services that would be included in that sort of capitated one payment model. So for instance, when it says primary care services, think about going to your primary care. You have an office visit with them. Well, that would be included, an office visit. But what if your primary care, what if you came in with a huge laceration and your primary care squeezed you into the schedule and spent 45 minutes stitching up your laceration? Is that considered a primary care service, or is that separate from primary care services? That's kind of what this is what services are considered essential in primary care that have to be delivered.
And then my last question, same thing, primary care provider. We don't have a definition of that yet?
No. Okay, so you might recall, because you've been here, we've done a couple bills, and we've done bills that reference primary care providers. And legislative council is always trying to reference something to define what primary care provider is. And there is no definition in statute. And so this was me actually saying to legislative council, hey, Jen, why don't we finally have a definition so that when we talk about primary care providers, we're all working throughout statute on what an actual primary care provider is, because we've never defined it.
And again, but this is studies. This is all gonna be studied. These questions are gonna be hopefully different answers, but then we go over all this stuff again.
But we haven't made any decisions.
No, but if this continues on, the study is gonna happen.
They'll send us a report on what they found.
Okay.
And then it will be up to the next legislature
Right,
to
right.
decide what to do with it.
That's what I'm saying.
Yeah, go ahead.
So I had asked yesterday, and I think last week I had mentioned how the bills that we're passing would work parallel with the rural transformation, all of it. And I just think this is necessary to, I mean, if we want primary care to work for all Vermonters, I think this just brings everybody together. Makes everything move down the road together, even if it is messy. Every agency is there and they're talking, and I think I just made me feel good. What made you feel good? This draft? Yeah.
Leslie,
did a good
did
job.
you want to comment? No?
I have one question.
Yeah, of course.
Maybe it's not understanding the Senate House interaction, but emphasizing the blueprint, it does feel like a little bit of an emphasis even in the purpose section. Is that to, I don't know, to align with the work that's been there to sort of recognize that? But because I think we're thinking more broadly than blueprint. And so I'm just wondering, like, if you put a period at the end of a framework for implementation of the universal primary care, is that that thing to do in the context of their work?
Well, because we have several sections in this bill around the blueprint and sort of optimizing the blueprint and having the blueprint look at itself.
Yeah.
Remember, this is just the intent section, so we have to put in the intent section what is in the bill. So we don't want to be silent on the blueprint.
Because it makes a clear appearance later, but you're saying lay the groundwork in the intent section.
Yeah, but which is why it's B instead. I mean, we have house health care A, and then we have Senate Health and Welfare B, and the bill that came over from us. And for better or for worse, we do have a 20-year history with the Blueprint for Health. And right now, the Blueprint for Health, I think it was the Vermont Medical Society who testified, the Blueprint for Health has actually already sort of built the relationships and the operational administrative capacity around distributing to primary care. So whether or not it'll be the blueprint isn't really, I think, relative. It's that it's what we have right now. It doesn't mean that's what we go forward with, but we currently have the blueprint. And we want the blueprint to function as optimally as possible, given that they actually are what we have now. This doesn't tie us to using that, but they're named because it's actually the only it's the only plan in place right now. I think the goal of what I was trying to put in here is, this is what we have now. Let's make sure that we're looking at it and using it to the best of its ability as it's currently configured, because frankly, I don't think we are. And I think that they will acknowledge the fact that they are, trying to optimize themselves. They're going through this process, but I don't think it ties it. It's just that they're frankly named because it's the only system. If you go back to that bill from 2018, it says, let's move forward with and decide whether it's going to be the all-payer model, the ACO, or the blueprint. Because at the time that bill was written, those three entities were possible. I think that this envisions that, maybe if the blueprint is maximizing and working at their highest function and it's working and the model is working, that, maybe they would be best positioned, but also it allows us to say, maybe that's not the best mechanism that we want to move forward with. And we won't know that until we have the information that's in here.
I mean, along that thinking, is it wrong to say after optimizing the blueprint for health, line 21, first page, to say, among other possibilities? So broad, so A is broad, B seems to maybe narrow it. Does it open it up again or align it with A to not only name blueprint, but say among others?
Actually, that's great. Why don't we ask Jen? Because there is later on in one of the report. Hold on, let me find it. Sort of section 8. We're asking them to come back to us and look at the ways, other methodologies, other funding mechanisms, other possibilities. Tell us what other states are doing. And there's a lot of innovative work being done in a lot of other states currently this year. And so they are coming back to us with, here's what other are doing. And I think it might be a good addition to, section B on page 1. Purpose of this bill is to obtain the information necessary to develop a framework for implementation of universal primary care, including optimizing the blueprint for health, determine whether it is an appropriate mechanism through which to provide universal primary care. And then we could say something like, or alternative, or if an alternative mechanism shall be developed.
Yeah, among others.
Among others.
That sets you up
Yeah.
with latter section.
I mean, we can't name anything because it doesn't exist yet, so what do we name? But we could, absolutely, I think it would make it stronger. I think the intent would be stronger to say, when we're not going down, we're not pigeonholing ourselves with blueprint. And we want to look at we want to make sure we're going in the right direction.
I mean, one of the things we could do is just how administratively burdensome. And hopefully that's something they're looking at like.
Oh. It always happens. No, I said, oh, well, maybe we can work with Jen to do this, and I like gave another word salad that I always do, and then you walked in the door.
You have to repeat the words.
Leslie.
I'm thinking back, if we're ready to think about second section, then that one, section 5, which is the one I'm struggling with. We haven't taken any testimony from any of these 3 groups or 4 groups for that matter on this idea. Are you thinking about that?
We could. And ask them about this section. I almost feel like all the testimony that we take on every single bill from these 3, areas sort of highlight the need, but if you'd like, I can ask
I think
each of, well, all 4 parties to come in and speak to section 5 and whether or not.
how that would impact them, what they think of the process. Because, I mean, as I've said, I've had concerns about it, and if I could be reassured, I'd feel better.
Okay. Can do that. So I see the Green Mountain Care Board writing down. I see the Agency of Human Services. Can I put out the invitation? And I don't see anyone from the Department of Financial Regulation, but we'll speak to them and have them.
I can definitely.
Yep. And the healthcare advocate.
They're in the middle of the board, Madam Chair, they're in the
Yes.
board meeting, so, and I've
Yes.
texted them my opinion, but that does not make policy.
Your opinion has merit.
So 6 months is pretty short. Because January 2027 is when you expect this report to be completed.
Yeah.
Well, I like that. Actually.
Everything else is January 15th.
Yeah, so by January 15th, I should expect them all to have convened and come back with a plan, including what they found out from other states.
Well, I think that what we're really getting at here is tell us about your discussions.
Okay,
Tell us what things were contemplated. Tell us what things were agreement.
tell
If
us
there
what
was
the
different- if
definition
there
of a
were-
primary
Oh,
physician
no.
is.
Well, that's a different report.
No, okay, but by that time, you expect there to be some sort of idea of a plan, concept of a plan.
I think that they will have had time to discuss amongst themselves the best.
Concept of a plan for what?
So the report is to begin a discussion on universal.
No. Are we talking about section 5? What section are we on?
They all seem to have a January 15, 2027 deadline on them.
So I would say that essentially section that one.
I don't
Section
understand.
3, Dr. Sarayan testified that this is what they're already working on this.
I guess about that.
I think they had a meeting yesterday, didn't they? I'm looking, I think there was a meeting yesterday. Yeah, he talked about how they're sort of in the process right now of modernizing. He was talking about, we're reassessing the quality measures, the administrative burden, so they're really already in this process.
Okay, and just help me. What do you expect? I mean, and what would be next steps? Is, I guess, where I'm just struggling.
What do I expect? Or what am I expecting? I'm expecting that if we put our legislative intent out there and that people know that this is where we want to go, that a lot of really, really smart, hardworking, skilled people we'll start working together and come up with a path forward that will at least culminate itself in next biennium, someone putting forward a well thought out, carefully planned, step-by-step bill that will get us to where we say we want to go. If you read back on, Jen, can you remind me what that bill number was from
S53.
S53? You go and you read that bill. That was section by section. First you do this, then we establish this, then we do this, then we do this. And I feel like for the legislature in the waning days of this biennium to throw words on a page with all of those steps is not a prudent thing to do.
No, I wouldn't, no.
So I think the intent of this bill is to set our intentions, where we want to go, and that a lot of people who do this work every single day to start thinking about how we get there so that next year we can come back with a fully formed path and on what needs to be achieved and how we implement it at each step.
Thank you.
That's
It's just hard to get from reports to what we envision. I'm just trying to,
well, I hope every member is back in this room next year. And we're the ones that make those decisions. So if it's our intention today, we're the ones that are going to be sitting here carrying out our intentions. So it's up to us.
which brings me to the last page. An act relating to.
The placeholder, I didn't want to try to retitle the name before you had talked about changes that were in the bill. So that will be something to decide once the bill contents are pretty set.
How about an act relating to reform for primary care? Because right now it says an act relating to payment reform for primary care. Just how about get rid of the word payment?
Awesome. So I'm thinking about these reports, and they're, oh, sorry.
No,
Yeah. And it seems like a lot of the content overlaps. I mean, it almost feels like it should be one report in some ways because it's, part A and it all fits together in this giant attempt to start something really huge and would be great. Could we be able to get there? But the reports, like one involves one set of people and then another is another set of people. And I don't know your thinking, so that's why I'm asking, is how these reports intersect and overlap. Like how does the work of that get done? And is that what the work of this committee is in January? Is that what you're thinking? Taking all these reports and then seeing how they fit together?
yeah, and also really sort of to your point of who do you pick to do these things? Which we're constantly in the role in this room of picking who to give something to. Maybe it should be overlapping a little bit so that we're getting better options, more diverse options, rather than like pigeonholing one person. So like, what do you said that a lot of them seem to have redundancies?
No, not necessarily. I mean, I haven't read every word. I haven't had time. We just got it this morning, you know. So I don't know the,
Just let everyone know, we're not voting on this today. We got plenty of time.
you know, don't know the details, you know, and that needs a deep dive. But if we're talking about definition of primary care services, per member, per month payments, I mean, those intersect. I mean, they have to, like you said, is the suturing for that terrible laceration included in routine care, or is it fee for service? We heard testimony from Dr. Song and others that something should be fee for service, like immunizations. So it's a lot of thinking, I think, that needs to happen. And I'm just wondering, you know, I'm just seeing this giant Venn diagram of all these reports and what overlaps and what does not overlap, and who's doing what over there and who's doing that over there. And I'm just a little confused, I guess.
Remember, nothing's happening with any of the reports.
No, we want them to happen. I mean, it would be stupid for them. I mean, yes, the point of the report is to create action, right?
Yeah.
So we need
Us
output.
action.
We need output that allows action.
Mhm.
So that's, I hope. I mean, otherwise, why do it? So,
Well, yeah, except we actually removed from the Senate version a lot of the action because we weren't comfortable with who was performing that action. I mean, you had concerns about the blueprint doing this, and so we actually removed the things that said that they then shall do
I
that.
understand that, because we wanted to open it up to a
Because we wanted to
broader,
open it.
yeah, you know, just to broaden our thinking, which
Yeah.
is good. I mean, I think that's good, but I'm just want to understand a little more about how these reports intersect, I guess.
Well, do you want to take time with it?
I will.
Okay.
But I don't know that it's my understanding that's necessarily accurate, because I didn't write this. So,
Jen, right before you got here, we talked about, page 1, line 21, line at page 2. Can you help us, actually sort of expand? You know, so we have including optimizing the blueprint for health to determine whether it is an appropriate mechanism through which to provide universal primary care or other methods, other alternatives.
Jen Carving, legislative council, Susan Beck. I'm not sure that that fits because I don't think you are obtaining information necessary to determine whether somebody else is the right fit.
Well, we have our look at other states, what other states are doing.
Okay.
So, you know, I mean, we don't have a named, but we have asked them to look at, you know, what other ways could
Okay.
something like this be structured? So other methodologies or.
So whether blueprint's not a methodology.
Great idea.
Yeah, I mean, we could say whether, I don't know, whether other structures or other approaches.
Probably can't write outside the box and statute.
whether other approaches would be, I don't know, I think we want to say a better fit, but sort of what, and I don't want to say appropriate because that suggests something is inappropriate. But yes, whether other,
Explored, other approaches to be explored.
well, it says optimizing, including optimizing the blueprint to determine whether it is an appropriate mechanism through which to provide universal primary care or whether
Other approaches might,
Be explored.
or other.
other approaches should be explored.
Or other approaches that arise from all these reports. That, you know, other approaches become obvious, other approaches that we learn about, other approaches, whatever.
Say, because we've used the word including blueprint, you can also say and including, and also including other.
Well, it's saying including optimizing the blueprint to determine whether it's an appropriate mechanism. So I don't think we need to say.
Or are there others? Could we just,
Right,
or
or-
might there be
Or
others
whether
Among
other approaches,
might be more suitable? Might meet our needs.
yes, I
might-
know, I think
Yeah.
may be more suitable to Vermont's needs, something
Yeah.
like that.
others. Universal primary care.
Is that, Sharon, is that, yeah, I don't know. Oh, I like, okay. Okay. Um. Anything else, or I suggest we end a little early?
I have a comment.
Oh, yeah.
Geez, right?
Hey.
Oh. Hi, Ryan.
Hi. Yeah, I was listening. I was waiting I was waiting for the right moment and you just kind of said this is it or we're gonna end for now. So I want to say it. My remaining concern is that we're gathering a lot of information that's important, but I still feel like we're lacking the focus needed to achieve the job. And we're not asking or delegating anyone with the responsibility of coming up with like a roadmap. Like, you know, we can get all this information, but it still would be good to have someone kind of do like like it's almost like a survey of the terrain ahead. And so I just, and, you know, we're getting some information. Like, I'm trying to think of like the analogy. It would be like asking someone to report on the climate and asking someone to report on the animal life and asking someone to report on some of the basic geographic features, but no one's telling us how to get from here to the top of the mountain. And so I'm a little nervous about, or a little skeptical, maybe it's not nervous, like skeptical that it's just going to yield a bunch of information and then in the first year, we're going to be swamped with all this other stuff next year. And then the second year, there won't be time to do anything. And then we'll be kind of in a similar position. So I'm a little concerned about that piece still. And I don't have an exact suggestion to make that hasn't been made already. I think the best thing would be is if there was a group tasked with coming to us with a plan or with a few plans. So that's just my thoughts. Thanks.
Fantastic thoughts, Brian. And let me be completely and totally transparent. That is the best thing. And I have discussed with anyone who would or has the capacity of doing this, just what you said. And they all required an appropriation. And there is no appropriation to be had. I also looked at forming a summer study committee. You know, sort of like what we did with education last year. It would require an appropriation. I thought about tasking the Health Reform Oversight Committee with coming back in January with recommendations and a fully formed thought. Health Reform Oversight Committee, I think, is appropriated. They can meet up to 6 times. I honestly had conversations with other people who are on that committee. And I don't think that people who are on that committee would be able to commit to the time that that takes. To be honest with you, I'm sort of hoping that committee members will, I'm hoping that all committee members will come back next year who are coming back, and then you'll work with me over the summer. And we'll come up with something, and we'll come up with a roadmap. Because that's the only thing I could think of didn't need an appropriation.
If.
Are you volunteering?
I was looking at the pay here. If the studies come back and, you know, everybody's on the same page, there's gonna have to be some appropriation of money to continue.
Well,
It's just not gonna happen without funds.
you mean universal primary care?
Yeah,
Or
Well, creating the plan even.
creating the plan, the whole thing.
It's gonna require
Yeah.
work.
Yeah. So, but we gotta find out what the study is, the results are.
gotta find out.
I love that you've done all that attempting.
I'm like exhausted at the thought of my summer ahead, to be honest with you.
But the oversight committee, I mean, everyone agrees how significant this issue is and how urgent it is and how it's taking too long already. And I'm just a little surprised there isn't a little more interest or capacity to, since it's already up and standing, it's already got its meetings. If there couldn't be some real.
I wanna mention, well, because it's in, yeah, I mean, in statute. The Health Reform Oversight Committee are the chairs of the 4 money committees. The chair of Health and Welfare, the chair of Human Services, the chair of Healthcare, Healthcare, and what is?
Senate member at large.
Okay, I was gonna say, how did he get on there? Yeah, and those same people serve on multiple other, like their JFC. There's, I'm not sure, they sit on a number of committees that meet during the summer. So, you know, if they're doing 6 here, 6 here, 6 here, I mean, that's a big commitment. I mean, I personally can commit to 6, but that's just because I don't sit on any other committees.
You'd like schedule it for the same day.
Try.
We tried that. We talked about that.
Thank you.
Um,
Well, I encourage that.
Schedule on the same day, but. Okay.
I have another comment or question.
Yes.
Just,
Yeah.
Penny, when you mentioned, you said a few minutes ago, you mentioned that it's gonna cost something eventually. Like, I agree, like that at some point, we need to invest in the proper studying of things if it's gonna be financially viable. And I don't think like legislators are qualified, honestly, for like we're not actuarial analysis, and analysts or whatever. We would need them to, if it was like the Health Oversight Committee, for example, or whatever committee we delegated this to that goes on year round, they would need JFO would need to at least spend money on it, if not additional consultants, I would think. So I'm just curious, like, did we ever see a fiscal note, or has there ever been an assessment of how much it would actually cost to invest in paying a group or paying analysts to do the work over the summer? Because I think that the cost of a working group, we have an idea of what that is because we've passed bills out of the committee with working groups. And sometimes that cost is considered de minimis if it's part of if it's able to be pulled out of someone's existing budget, which, so it's not a lot of money to pay people a little bit to just be on a group. I think the issue comes in when you're hiring actuarial analysts, because I remember like past studies being like $100,000 or something. And so I don't know if anyone, or Alyssa, I don't know, our chair, I don't know if you had a chance to talk with JFO, if we had any idea like of how much it might cost if even if we're not going to do it now because we don't think appropriations will appropriate money to it. I'm curious if we have any idea how much it would cost.
I did not ask JFO to come up with it unless you have a set number that you think.
For the record, Noel Lang, joint fiscal, Rep. Tina asks a good question. The answer, just like the other study, depends on what it is we're studying. Depends on how broad or how specific it is. So it would depend, because if you were actually doing a study like we did for the Universal Unified System, you would say, we're gonna look at this, and this, and each one of those would have a cost. So it depends on what it is you want us to look at. Do you want us to look at reimbursement rates? Do you want us to look at the impacts on macroeconomic, microeconomic? So the answer is it all depends on what it is you want us to study. And that would depend on who we have to hire and how many consultants. So the answer is it depends on what it is you want.
Can I ask, can I put a few things out there? And if you don't know, it's okay, but I'm wondering, one, and I could probably look this up online, but I think it's important for the record to put it out there. Like, I'm wondering how much the study cost. I think it was in 2014 when I can't remember his name. Was it Shao report where he came forward with 3 different pathways? Like, how much would something like that cost? And like if we wanted someone to actually crunch the numbers and say, here's projections on how much it would cost per year. Here's how you build the public, financing aspect of it, and here's sort of the projected impact on premiums over time. Like, how much would something with that level of detail cost?
Sure. So if I can jog my memory, I believe that contract was somewhere between $500,000 and $750,000. However, Dr. Shao donated his own time pro bono and used a lot of graduate students because he was doing it through Harvard. So that cost was cheap because he was willing to do a lot of the work out of his own pocket.
$1 million.
Well, that's for that. I mean, again, and you got a cost for inflation, and again, it all depends on what it is you want. The bigger question would be, what did the administration spend when they were trying to figure out what it would cost? I mean, they hired tons of consultants, tons of people. That to me would be a bigger question.
Okay. We should end for the day. So we'll come back to this. We've got it here on 6/11 tomorrow, and then we'll come back to this tomorrow. Thank you, everybody.